First part of the digestive system is the oral cavity. We also call it the buccal or buccal cavity. This is going to be lined with stratified squamous epithelium, and specifically it's going to be kind of protective, because remember, if you have multiple layers of epithelium, it can slough off or die off very much kind of often and can be replaced because there's multiple layers, and it's protective. So we say resist abrasion, meaning there's a lot of rubbing, kind of things are moving around in your mouth. So there's a lot of damage that can happen to the epithelium. So having multiple layers helps that. Your gums or your gingiva, your hard palate, so the top part of the superior part of your mouth that's hard, and part of your tongue is actually keratinized. So remember, keratinized is extra protection, where these top cells are packed filled with the hard protein keratin to help protect them even further. The rest of it's going to be non-keratinized for kind of moisture purposes, but we have some areas, again, that are keratinized for extra protection. So the point of the mouth or the oral cavity is the site of mastication. And when we masticate, that is the fancy term for chewing. So remember your masseter muscles for mastication. You move your jaws to move your teeth for chewing. It also, again, makes the way between the tongue and the teeth and saliva, it transforms the chewed food into a ball, which is called the bolus. The bolus is just easier to swallow. It's easier to make it into this kind of neat little ball of food mixed with saliva that's kind of soft and flexible that can be swallowed versus having just stuff all over the place. So we just kind of make it in a neat little ball so it's easier to swallow. Then we have salivary glands. We have three major ones. We have the parotid, which is going to be kind of near your ear, sides of the face. We have submandibular, which is going to be under your mandible. That's the sub is superior, or sub is inferior, so under the mandible. And then we have sublingual, which is under the tongue. Lingual is tongue. So you have the three major salivary glands. What do they produce? They produce saliva. What's the function of saliva? It's kind of wash out the mouth. So if there is food just left in there, it can kind of wash it away. It helps with taste. So dissolving chemicals in saliva helps the taste buds actually sense taste. And the major one is going to be it moistens food. So it adds moisture to that food and helps make it into that ball or that bolus so that it's easier to swallow. And the other one is it's going to start the breakdown of starch or carbohydrates in your mouth. So it has an enzyme called amylase. And so we call it salivary amylase. So the beginning of digestion of carbohydrates actually starts in your mouth. There is going to be other enzymes, but this is going to be our major one. Amylase, salivary amylase, starts the breakdown of starch or carbohydrates in the mouth, and it continues until it's completed in the small intestine. The salivary glands have two types of cells that are making stuff or secretions. So they have serous cells that are going to produce mostly water, which is going to be most of what saliva is mostly water. And then we add the enzymes. Again, salivary amylase is going to start the carbohydrate breakdown. And there's also some ions in there that we'll see next. Then you actually have the second type of cells, so it makes it a little mucusy. So saliva can have a little thicker. Obviously, it's thicker than water, and sometimes if you're a little more dehydrated, it can be even thicker. So it just helps kind of smooth movement of the bolus as well down in through the pharynx and the esophagus into the stomach. So looking at what saliva is mostly water. 99.4% is water. It is slightly acidic. That is immune function. So remember in that section, pretty much if we have a slightly acidic, we're trying to protect against bacteria. This is an opening to your body, so you want to protect it in any way you can. You have electrolytes like sodium, potassium, chlorine, chlorine, phosphates, and bicarbonate. So this is going to be a buffer that's used a lot. So it's going to help kind of manage pH. Again, we have the enzymes. We have salivary amylase. Whenever you have an amylase, it's with carbohydrates. And we also have a lingual lipase. This isn't a major fat breakdown enzyme, so we're not worrying about it too much. It's more kind of like milk fat and things, not kind of what we're talking about when we talk about bile. You also produce mucus, protective enzymes, lysozymes, and protective antibodies, IgA. And there's even some urea and uric acid, a little bit. We don't want tons because that can cause issues, but there is a little bit of metabolic waste there too. Looking what else is in your oral cavity is your teeth. So 32 total permanent teeth, so adult teeth. And there's 4 major types. There's incisors, which are going to be in the front. So your front teeth or your most anterior are going to be your incisors. Those are for kind of clipping, kind of chew on a little bit, kind of grab, and it can cut a little bit as well. You have your canines, which are next to it. So you have 2 kind of, if you're looking at upper jaw and lower jaw, you have, and this is just one side. So you have 2 incisors in the front. And then next to that, you have your canines. Those have a really massive root. Those guys are for tearing and slashing. So really grabbing into food and kind of tearing it and mashing it, not mashing it, slashing it. So kind of tearing and pulling it apart. Then the next we have premolars. They're also called cuspids and bicuspids. So some of these can have 2 roots. You can also have 1 root, but you can have 2 roots. So you can see 1 root here and 1 root here. Those are more for grinding and crushing injuries. So they're flat. So you have canines that have more kind of pointed. These can be a little flatter. And grinding. And then last, your back teeth or your molars. So there's going to be 3 roots. These are big teeth oftentimes. They can have 2 or 3 roots. And these are grinding because they're flat too. So you can see they're really flat surfaces for really grinding and crushing as well. So food passes from the mouth or the oral cavity into the oral pharynx. So remember, the oral pharynx is the area of the pharynx that's posterior to the oral cavity. And then it travels into the laryngopharynx, which is posterior to the open epiglottis. The pharynx is now still going to be stratified squamous epithelium, and you still are producing mucus because you want things to slide through here. So you want protective nature of the stratified squamous epithelium, but mucus is going to make it slippery so that it can slide through because the pharynx is going to be connection to the esophagus. So you want the bolus of food just to slide down and go to the esophagus. So mucus is going to help, and it's another protective part as well because it can be rough and damaging. The pharynx is muscular, so it's going to be made of skeletal and smooth muscle, and then its connection again. We have nasopharynx, which is the connection posterior to the nasal cavity as well. But this is connection between the oral cavity and the esophagus. So things that you're swallowing from your oral cavity go into the pharynx and lead into the esophagus. Pharynx has a role to play in deglutition, which is the fancy term of swallowing and breathing. because remember kind of what hole goes down. So if you are breathing, then the epiglottis is going to be open and air is going to go down into the trachea. If you are swallowing, then we're going to close the epiglottis, close the trachea hole, and it's going to go down into the esophagus, into the stomach. So it just depends. It's kind of a gateway between the two tubes and two tracks. The esophagus is a muscular tube as well, made up of skeletal muscle and smooth muscle. Goes from the laryngopharynx and connects it to the stomach through the thoracic cavity. It's a flat tube, meaning it kind of flattens down when it's not filled. So if it's not filled with something, then it's just a flat tube. This is going to move food or liquid, whether you're eating or drinking, to the stomach. And like I said, it just kind of flattens or collapses when nothing's in it. It's, again, just like with the pharynx, lined with mucus. So we have mucus producing cells. Oftentimes these are going to be goblet cells that are going to make mucus. Not only, again, is it protection, so making sure everything's moving smoothly, and not causing damage, and it also helps be slippery. So it helps the bolus move down the esophagus. So we help it kind of slide down the esophagus and help protect the tissues. So it opens into the stomach when we call it the lower esophageal sphincter. So what happens is comes down the esophagus, and we have a muscular kind of circular muscular sphincter that's here that can open and close. Why do we have an esophageal sphincter? Well, we don't want this open all the time because what's below it is the stomach. What's in the stomach? A lot of hydrochloric acid. Hydrochloric acid has a pH of about 1 to 3. The stomach is made to tolerate hydrochloric acid. That's the point of it. The esophagus, not made to tolerate hydrochloric acid. So you want to keep this closed unless a food bolus is coming down the way and wants to go into the stomach. You want this closed because you want to contain the hydrochloric acid in the stomach. You only want to open it when something's traveling through it. So inadequate closure of the lower esophageal sphincter. So if you have a little bit of a hole or an opening here, that leads to GERD, or gastroesophageal reflux disease. And gastro means stomach, esophageal means esophagus, and reflux means it's going backwards. So what's happening with GERD, or you can think about it as heartburn, so causing issues, is the hydrochloric acid. This isn't closing as much. Well, hydrochloric acid's going up that way. So it's going backwards towards the esophagus, because again, as the stomach's contracting and squishing all the time with a smooth muscle and pushing and churning, then some of the liquid can slosh into the esophagus. Again, the esophagus isn't made for it. It has protective mucus and stratified epithelial tissue, but it's not made for the hydrochloric acid. So you're going to cause damage to the lining of the esophagus, causes inflammation, causes pain, causes discomfort. So that's what's leading to GERD, or gastroesophageal reflux disease. So the mucosa, so that's going to be the inner layer of the esophagus, is non-keratinized. It's not hardened, it's for moisture, but still protective where it's stratified squamous, because we can have a lot of abrasion coming down through the esophagus. We also have a muscularis externa, so that's going to be the external muscle layer. Some of it is going to be, so the superior third, the top part, is going to actually be made up of skeletal muscle. And then the middle is kind of a mix, and then we go to completely smooth. So it actually transitions over time. So we have the mucosa, which is kind of the lining. We have submucosa, which is under the lining. Then we have a muscle layer, and then we have the outer kind of layer, which is called the adventitia. Now we're going to talk about deglutition. Deglutition is actually the coordination of a bunch of muscles. We're not going to list all the muscles or anything like that. We're just going to talk about the overall process. So you have two phases. One's voluntary, one's involuntary. So you actually decide to swallow. You've chewed and you're chewing and you're okay, I'm ready to swallow. So that's voluntary. You think about it. And that's called the buccal phase. It's contraction of your tongue. You actually push your tongue up so you can push the bolus into the back of your mouth, back of your oral cavity, right to the entrance of the pharynx. Then we have the pharyngeal and esophageal phase, which is involuntary. Once you start swallowing and you decide to swallow, it's going to happen. So this is going to be an involuntary, and we have contraction. We're going to go over steps. And this mainly involves the vagus nerve. Now remember, the vagus nerve is the main parasympathetic nerve. So remember, parasympathetic is rest and digest. So this is part of digesting. So the vagus nerve is going to be involved in swallowing. First, the buccal phase. Again, is voluntary. You decide to all of a sudden swallow. What happens is you push your tongue superiorly or up and smush that bolus, that ball of food, against your hard palate, the roof of your mouth. So against the hard palate. You push the tongue up and it pushes the bolus back to the posterior part of the oral cavity and then goes into the oral pharynx, so into the throat part. Once the bolus is into the oral pharynx, so you've gotten it to the back of the throat and you're ready to swallow it, then you're going to have the automatic reflex. So again, getting the bolus to the back of the throat to the oral pharynx stimulates the involuntary phase, the next one. So now we're looking at the pharyngeal phase. So we have the bolus in the back, and then what happens, there's different muscles. Again, I'm not going into specifics of muscles, but you contract pharyngeal muscles, so muscles in the pharynx. What happens is the epiglottis is folded, so you are covering the entrance to the trachea because you don't want the bolus to go down into the trachea. You want it to go into the esophagus. So you actually elevate the larynx. So you push it up and push it superiorly so that it can meet the folded epiglottis and cover the hole to the trachea. You also move the soft palate and elevate the uvula. The uvula is that hangy, dangly part at the kind of inferior part of the soft palate. So we have hard palate here, and then we have soft palate here, which is muscular, fleshy. And we're going to elevate that superiorly. So we're going to move it. Why? Well, then we don't want bolus going upwards and backward into our nasopharynx and our nasal cavity. So you're kind of just closing roads off to direct the bolus into the laryngopharynx and eventually into the esophagus. So you're just closing off the roads. Close off the uvula and the soft palate to the nasal cavity. You close the epiglottis to the entrance of the larynx so that the bolus has to go into the pharynx, the rest of the pharynx, and down into the esophagus. Then so we've gone through the pharynx and now we're in the esophagus. So then bolus is moved by peristalsis. Remember that movement of constriction behind it to move it forward. Once we get to the inferior part of the esophagus, so peristalsis has moved it all the way down through the thoracic cavity to the um, lower esophageal sphincter. That so when it's getting towards that part, this is going to cause the sphincter to open and the bolus can go into the stomach. And the esophagus travel time is very quick. So when you swallow, sometimes you can swallow, you can actually feel liquid if it's really cold go down. It can be really fast going through the esophagus. Sometimes gravity helps that too. And then even food. If you swallow something, you kind of feel it go all the way down. It doesn't take that long, 9 seconds for it to squish all the way down into the stomach. So again, the esophagus is just a connection between eating and chewing, and then the stomach where we kind of continue digestion.